So good morning, all the officials, experts, panelists, participants. So great pleasure இது. So இன்னைக்கு இந்த மீட்டிங் நடக்கிறதுக்கு எல்லாமே நான் அடிக்கடி சொல்றது வந்து it's because of the team. So you all there, உங்களோட everyone's contribution தான் things are happening. Yesterday the program which went on very well beyond our expectations, it's because of the contribution by each and every one of you. First, hats off to each and every one of you. Within a shorter duration, you could able to bring out the biggest challenge possible. It was much appreciated by all the delegates who were there and all the people who watched the video also. Even I got a feedback also. It's very good. Keep it up. See, the ultimate aim for this type of conference is that learning. See, this is critical. The entertainment which we had yesterday, we'll have today and tomorrow. It's just a small substitute. But the ultimate aim is that we should refocus our attention on the research. We should develop local research. That's a real aim. How will we do it? We'll just think about it. As we are celebrating this 100 years, we are thinking about the areas in which we are supposed to focus. We have identified certain areas, but while looking for international evidences, so what is there, how it is there, I come across one article which I mentioned yesterday also. The Lancet has completed 200 years of survival. The first issue was given on October 5, 1823 from London. 200 years. See, with the 200 years of experience, what they want to focus is just 5 spotlights, which they feel this is the need of the hour. If you are able to put our attention on these 5 areas, definitely the public health or whatever the health of the community will be taken care. Those 5 areas, it is UHC, the universal health coverage, it is mental health, it is adolescence health, and research for health, and it's a climatic change. These are the big 5 areas which each and everyone should focus for continuation. See, actually, in our team also, if you go through it, almost the same areas are being focused with a little bit of tweaking on this side and that side. And few things were added, including your IT, artificial, and all those things were added. And we will have an expert, which our minister, our IT minister will be joining. He's an expert in the financing. He'll also speaking. Either why we are not able to do it, even though we set in the similar agenda, somehow we couldn't do it in a systematic way. Why we couldn't do it? So, 2 things which I come across my mind. So, one day, even though we always take WHO guidelines, CDC guidelines as a dictum, slowly and slowly. See, initially when these things were started, they were the social reforms, they were the political agenda, they were everything. But slowly now you see the way in which it's functioning, it have a little bit of worry from the experts. See, the entire funding of the WHO is being given by the different agencies and at different stakes. In fact, different officials at the higher level also being, it's not a pure scientific process in which undergoing. Rather, I will put it in a simpler way, the health agenda being fixed by the funders, the World Bank, rather than by the WHO. See, our idea is that the technical expertise should decide what is to be done. See, the finding a resource is another area, but unfortunately, we are slowly moving towards an area where the decisions are taken by the funders. What e-funds, it's happening. In fact, there's a quote in the Western globe saying that, let us think beyond Bill. See, now the Bill Clinton's with his huge investment, he decides the area which he feels is correct. See, many times he may be right, but there is a chance that there's a skewed opinion. So because of this financial power, our big agenda may get diverted. So I'm not saying it's diverted, may get diverted. There's a potency. See, unless and otherwise we could establish the scientific basis with the influence of funders, it may move away. See, now the Warren Buffett can decide, Elon Musk can decide your health agenda. See, it is based on their perception. See, everyone's perception may be different. The perception is based on their understanding, their development, but it need not be the same. Let us develop the scientific knowledge. If it is so, why couldn't we also do it in a similar way? See, I usually quote a little bit of word saying that it was a colonial research. So initially, it was from the Western world. They have taken a lead. Since they have taken a lead, they continue to be in the front. It doesn't mean that we don't have that research capacity. We don't have that infrastructure. So we have everything. Unfortunately, we are not putting into use. See, this conference, you could be able to do it within a span of 1 to 1.5 months. This is our capacity. But unfortunately, if you give this to a Western world, they will plan for a year, and definitely they'll invest much resources what we are doing it. See, this model, what we are trying to do is a self-sustaining model. This entire program is funded by you, participated by you, and it's getting expanded by you. So this is the model which we should do it for the entire research. See, always this local evidence, which we call it, will sustainable. See, and it's become adoptable. See, if you can adopt Western world, it will work for some time. Unless you have that little bit of tweak, it will not happen. So how to do this local research? This is one of the agenda which we need to talk. To start with, we had a small newsletter being coming up in our DPH side, where most of the activities, sometimes picture, but sometimes activities are listed. And we also have a journal, quarterly journal, which is being released. It's all available in our social media. And to develop this, we are given a small concept of, let us produce 100 journals, 100 articles in 100 days to celebrate our 100th year. This is our 101 year now, existence of department. It is doable. See, there is a challenge. In fact, when we say that 100 articles, 100 naal, people were imagining it was not possible. But we could able to do it more than 89, if I remember correctly. What we have done is that we just are the small, young, potential medical officers and other people who have a little bit of interest in this. We have identified. Fortunately, we have mentors from both JIPMER, NAE, ICM, all those things. We just told them what to do, how to do. A small intervention. Third, as you already know, we have a huge data with us. It's a data mine. The entire department, which has got more than 60 to 70 programs, covering 8 million population, imagine the data which we have. So if they are able to do it, we are given a secondary data only. With this, we could able to give around 90 in 100 days time. This is the biggest possible. This is what I say is the potency. If you are able to explore this potential little more further, the research can be done. See, when we see the opportunity, why we couldn't do it earlier? Because the earlier, our focus was food. There's a challenge for our survival. So our entire focus on how to make a livelihood. So again, whatever available, we are continue to eat, continue to manage. This was out of our focus. Now, here also, with the skewed eating, the lifestyle diseases become a bigger problem. So because of this, ultra-processed, easily available, market-driven, processed food make you obese, make you prone for many other problems, and we are continuing to treat. See, unless and otherwise we address the so-called risk factors, which are regularly emerging, it's going to be a big problem. How we do this lifestyle modification? We've done a small intervention for your health walk. This is a primordial prevention. If you do it, definitely we can have a big. And one more area which I feel which we need to focus after some time is that the so-called lifestyle modification or small intervention is your nutritional intervention. See, primarily the food processing industry which we started, it's mainly for the food security. Now we need to focus on the nutritional security. There's a difference. See, at the time it's mainly to make how they expand the lifespan of the product so that it's available everywhere. Now, because of this ultra processing, the nutrition values drops because of the dense consumption, the dense, highly energy dense product, the youngsters are getting in fact addicted. See, sugar is the biggest addictor. So it's more than your tobacco and alcohol. And if I see, in fact, I was discussing with my additional director yesterday also. See, one side you are talking about putting a tax for the so-called sin tax on a tobacco, alcohol, and sweetened beverages. But if you see the market, the PepsiCo market, sugar segment, quarterly increase is continued to rise. Your chips and sugar market of those companies are continuing. That means, where is our intervention? See, unless and otherwise we reverse that intervention, the health risk factor is going to be there. Everyone is going to get diabetic, obesity, hypertension. And with our intervention, see, we have done MTM, Makkale Thedi Marthuvam, we could able to reach 1.16, but this will not be a sustainable one. See, imagine the economic aspect of managing this, and with 1 or 2 years, it's going to be the complication screening. See, your diabetes, your management of just few drugs as per the protocol alone is not sufficient. We need to screen them for complications. Your neuropathy, nephropathy, retinopathy is going to be a big challenge. See, unless and otherwise do an intervention, you cannot reduce those big complications. How we are going to do it? In fact, I used to quote often, our insurance is around 1,000 crore annual budget. The maximum utilization in that is your maintenance hemodialysis. If you are going to spend your entire money on maintenance hemodialysis, what about the rest things? The only way is that you should control your hypertension, diabetes, either through MTM or any other intervention. Otherwise, sustaining a maintenance hemodialysis, it is impossible. Including, imagine about the suffering that individual has to undergo. 3 times in a week, our sir will know about these complications. And even if you talk about the renal replacement, we'll say it's available. In Tamil Nadu, we give free of cost. Insurance all up to 4 to 5 lakhs, it's free. But still, it's another big catastrophe the individual has to undergo. So if you want to prevent all those things, this is where your intervention. One of the nutrition intervention, right now it's become a fad that it's a millet magic. Yes, if you take millet, everything is taken care, you need not to take rice. But we need to understand the market behind it. It's always the demand supply. Without increasing the supply, if you increase the demand, the price will become higher and higher. So it becomes unreachable for most of us sitting here. We know that we should take millet, but it's beyond the reach. Then another side is also that, from the farmer's point of view, you should have a better earning for the acre or the investment which you make. See, if he earns more from the sugar cane in an acre, his priority should continue with the sugar cane, not with the millet. See, just for your health, he will not change his priority. Because that's the one which is his livelihood, he will continue to do it. See, unless we tweak it there, it will not happen. And again, millet, you need to have a little more easy to do it. See, we'll say that, no, usual follow the styles. Now, people will not adopt it. Now, your Maggi and noodles are adopted because of the easy to use, easy to cook. The similar thing should happen even for your millet. See, this is the big cycle, and mostly it's driven by the industry. It is not the health industry. It's not the health agenda. It's an industrial agenda. But if you are able to tweak this for the health care, definitely this also can be taken care. And yesterday I was talking about commercial determinants. See, so far we are all talking about only the social determinants, basic. See, unless and otherwise this commercial advertisements were taken care, it will be a big challenge. See, we all know about the nutrient value. நம்ம எல்லாருமே இனிஷியலா படிக்கிறதுல எல்லாமே படிச்சிருப்போம், whether you are a nurse or a doctor. எல்லா லேபிள்லையும் வந்து you will have how many grams of carbohydrate, salt. But அது நம்மள படிக்கிறதே கஷ்டம். அது படிச்சாலும் we may not understand what it means. Are you taking more than the required daily allocated allowance using that one packet of chips? No. None of us can determine. When it is the set up as, imagine the common people, how they will understand the value. For the legal purposes, they say all these things were labeled. But unless and otherwise, it is translated into a common man's language. See, a common man should think that if we eat this 100 grams of chips, I already crossed my daily requirement of salt. I already crossed my daily requirement of trans fat. I crossed my daily requirement of salt. Unless and otherwise he understand, it will not going to happen. See, for the legal purpose, now this is a big concept of nutrient rating, the front of package, labeling, all those things come, but it should be in a common man's language, particularly for the adolescents. See, the pizza and all those things were very nice, very appealing, but how much damage it comes, it should be known to the adolescents. The big problem is we are kept them on ignorance. See, now the youngsters, which they talk about climatic change, definitely will understand this concept also. Taste-க்கு ஒரு நாள் 2 நாள் சாப்பிடுவாங்க, but if you continue to eat, what is the challenge? They should understand. Once they understand, take it sure, they will change. They will go for the good. Again, the big problem is the affordability. உங்களுக்கு பரோட்டா வந்து highly dense parota, you will get at the cheapest rate. If you think about fruits and vegetables, it's costlier. எனக்கு கிடைக்கிற 100 ரூபாய் வருமானத்துல where I will invest? First to fill my stomach, then you talk about nutrition. This is the difference. Unless you attack this difference, things are not going to change. And another area which we are talking about is see, all these things are there, and why we are not going in the direction which you are expecting is ultimately it lands on a financing. See, where the financing, the activity is moving on. Whether you like it or not, this is the reality. So now we need to plan in such a way that how we can finance more in a primary care, more in a prevention. This may not be a political agenda. See, again, I tell you, see, with all governments, in fact, in our state, all the successive political governments support health. At the same time, the name and fame which they got by building an institutions will not be there for them to do this. See, what is our role is that as a technocrats, we should get this into their mind. This is the value. And this is how you are going to take care of the entire population. This intervention, if you are able to do it, we can bring it. If you talk about financing, there are major sources. You are state funded, center funded, local body funded, but this alone will not be sufficient. The so-called CSR, it's a huge money which we need to plan to divert into the primary care. So this is a huge potential. See, there are so many venture companies, we are ready to relocate the potential. In fact, I remember you are talking about HCL Foundation, how they support the primary care intervention. See, now there are one source of people who are ready to fund, but they don't know where to fund or how to fund it. They simply go build again buildings. That's not going to be the source. Now we should, as a technocrat, we should plan in such a way that all these ideas, concepts, trust, foundation should be rooted to primary care. That's the way into it. And health insurance also, I was in insurance for almost a decade. It should not be seen as an insurance. It's an health security. See, with this alone, we can move forward. The big challenge or big advantage is that we will design a health benefit package. See, if you are able to design this health benefit package, we can control the indications, we can control the expenditure. We can tweak this in the way it requires the community. So in fact, I used to say, if there is a misuse is happening in the tertiary care, we should be extra careful. But if the misuse is happening in the primary care, we should accept it. See, after all, for more screening, earlier diagnosis, nothing is going to happen. In fact, there will be a betterment to the community. And in the similar way here, we need to work with the private sector. Whether you like it or not, we have an inhibition that government sector should not work with private sector. We always look them with a suspicion. It is not the case. See, there are good people everywhere, there are bad people everywhere. Let us not worry about this. But if you are able to know where exactly you should take the support from the private sector, it will have a huge support. See, they are, in fact, they are the friends of innovation. They are the early adopters. So before the government adopts, there is so many local private institutions who are willing to take risks and adopt. For them, it's a market, but still, they are the early adopters. If you are able to follow them, it will have a big thing. Third area which we were talking is the UHC. See, the universal health coverage is nothing but your all required services, acceptable to them, accessible to them, affordable to them, and at the quality at which should be given. See, now we see UHC as a one program, put some health mela, put some poster, get it over. That is not the intention. See, we should be in a position to give an equitable care. Whether you are on a higher level or a lower level or whatever community you are, whatever financial level you are, you should get the same level of care according to your need. See, if you are able to ensure that, things will happen. But this UHC, which is a bigger goal, if not achieved today or tomorrow or even after 10 years, let us not worry. But this is the direction under which we need to travel. If you are not doing it, again, everything will be skewed, including your all the resources. The UHC, which should aim for it. And adolescence, again and again, we are focusing it because the risk factor emergence is happening in the adolescence. If you are able to modify their level, definitely your healthcare costs, the sufferings will reduce when they have become adult. Two interventions we usually talk about. Change your lifestyle modification. Munadi, we used to play at least half a day in the schools. Now, nothing. So, every day, only book, your physical activity is gone. That's why your BMI is increasing. Now, almost 40 to 45% were adolescents were obese. Another 20 to 25% were undernourished. See, literally around 60% of our population in the younger generation are unhealthy. See, this is the big challenge. This unhealthy population is going to be a big challenge for us in the future. How we are going to address? Simple lifestyle education, simple sexual education, all those things, if we are able to do it in the adolescence age, we can change. And next big area is the anemia. It's not only nutritional, other challenges also there, including our own people don't take medicine time also. This also we can plan for it. Then your climatic change. See, this you may not see the impact now, but what is happening today or a few days in Chennai may be an impact of this climatic change. We don't know. And the dengue increase, it's before that it should be a few season. Now it is throughout the year because of this climatic change, vector modification, we don't know. And all those unusual drought and flood may be because of this, but how you can talk about, see, experts can talk about carbon footprint, carbon monitoring, blending with ethanol, CO25. See, all these things are possible, but the smaller interventions which we can do it at our level, if you start, definitely there will be a big change, and we will come out with a lot of activities also. We have a sessions on this in future. Another point which we need to focus is your mental health. See, previously it is only a stigma. Tobo, why should I go? Why should I, if someone in the family is challenged? Now, I see little beyond now. See, we have created an awareness, we have created a demand, but supply is very bad. See, if there is anyone in the family, if you go to therapist, the therapist session, he will charge not less than 1,000 to 2,000 rupees. Many people need it over 2 to 3 sessions in a week, continuous period. Imagine over 25,000 monthly income the family is having. If you are going to spend not less than 5 to 6,000 rupees, the impoverishment, the out-of-pocket expenditure is gone. The poverty sets in. See, we are all talking about 10 to 25% of your annual family income is reaching this, empowerment sets in. This 1 or 2 mental health problem is going to be a huge problem, mainly because of the therapy. The therapists are available, the cost is so high. The only way is to integrate this mental health also in the primary care. See, giving drug is only a small component. நம்ம psychiatric care na நினைக்கிறோம் வார்டில் போடணும் மருந்து கொடுக்கணும் மாத்திரை கொடுக்கணும். It is not that. See how early we can diagnose, how continuously we can treat it. The primary care will become sustainable. We should plan for it. And related to this is your elderly care. See, now the society has become aging. Another big challenge is we so-called we are digitally connected, but actually the social disconnect is there. The society has become also little more selfish. So aging, selfish, disconnected society. The elderly population living alone is increasing, particularly the women, the rural, who is not having any financial support is increasing. This is going to be the big challenge. See, we as a government got a big role in this, and there may be a time where we not only need to provide them home-based care for these people or outside the home also, but we need to be very clear in our understanding. This is not the hospital care, this is not the hospice care also. Something in between we need to plan for the elderly, because there will not be anyone to take care in the family. So the same thing may happen for all of us in future. So this is another area which we need to focus. And finally, if you want to achieve everything, I am a strong believer in this IT, strong believer in the AA. See, AA is nothing but you are understanding the pattern, put it based on the things. See, this is the only one thing which can give you a result in a mass scale. Please don't understand it as an cost-cutting tool. Please understand this as an enabler. See, there will be a challenge with us or with the machine. See, we need to work together with the machine. See, the idea is that we will increase the capacity of the both machine and the human being. At the same time, each of them should mutually complement to reduce the challenges which we call it as a humanified artificial intelligence. If you are able to do it, we can do big things. See, it has got a huge potential. So we can increase your prediction of your output, the diagnostic prediction, the trainings. So anything can happen with your IT. In fact, we had a very, two things which we have, yesterday also we have done. One is your civil works monitoring. See, for an example, in our department also, we have more than 2,500 works happening simultaneously, worth for something around 600 to 800 crore. See, unless we have an IT tool, we cannot monitor. See, every work will be in a different stage. Basement, lintel, painted. This 2,000 into 5 different funders, 3 to 4 different executors, and almost 10 levels of progress, it's unimaginable, and you cannot do everything in a manual. Yesterday, our team has introduced an application to monitor this. The similar way, monitoring of biometric attendance. We already done your, what do you call it, as HIMS. We have done already your DDMS. See, this is all drug management. How we can do it, this can be done. And finally, what we need is that change within ourselves. See, this is all known to us. What we expect is an organizational change. See, this should be everyone's agenda. And it is not that only I do, you do, other people can take the right. It's everyone has got a role. In fact, நம்ம வந்து இந்த கான்ஃபரன்ஸை வந்து டீமாக கொண்டு போகிறதுக்கான காரணமே அதான். சரி, நம்ம டீமை பொறுத்த வரைக்கும் பார்த்தீங்கன்னா ரைட் ஃப்ரம் த கிராஸ் ரூட் லெவல் விஹெச்என் ஹெச்ஐலேருந்து டைரக்டர் வரைக்கும் ஆல்மோஸ்ட் 200 கேடர்ஸ் ஆர் தேர். Almost 60,000 employees are there. See, everyone has got a different level of understanding, different level of capacity. But unless and otherwise we go as a team, the goal of public health department will not be achieved. So this change need to be brought in. That's another big interest or the concept or the objective of this workshop. So